She has a working experience of 17 years in pediatric departments. Other than her work, other than her duty job, she has done other activities like she had participated in oral research presentations, which was conducted in Nigrims. She has done in the KMC Tertiary Care Hospital a qualitative improvement initiative in the year 2023 itself. And she is also a member of TNI. So thank you so much for being with us, sis. Today we have a guest speaker. Madam Tasi is here with us. Ma'am is working as a principal in College of Nursing here in Nigrims itself. So she has done her BSc Nursing from Regional College of Nursing, Guwahati, and cleared in the year 2001. And done a master's in child health nursing from Rajkumari Amrit Kaur College and passed out in the year 2006. She has a working experience of total 17 years, especially in the teaching area. And during her career time, she has done so many publications. As you can see here, she has done an undergraduate research guided for 15 batch, postgraduate research guide 13, and individually also she has done so many research projects here, and even has done the publication in national and international journal. She has been an examiner for various universities like AIMS, NEHU, PGI. And during her career, she has organized and participated in many workshop, conference, which has been conducted either in national level, state level, or regional level. And she has also worked as an ad hoc INC inspector. When we are talking about membership, she is a lifetime member of different associations, as you can see here. TNI, SOMI, Oncology Nurse Associations of India, Asian Association of Cardiac Nurses, and Indian Associations of Neonatal Nurses. So thank you so much, ma'am, for joining with us, and we are very much happy to have you here with us. So now we will start our today's sessions. I think my slide is visible.
Yes.
Okay. Okay, so I request Sister Amila for the presentation. Over to you.
Thank you so much, Nanuka, for the introduction. And thank you so much for giving us the privilege, especially the pediatric nurses, to come forward and share our experience. I know it was not an easy job. It was quite tough and challenging, but thank you so much for encouraging and bringing us up to this. And good afternoon, everyone. I also would like to welcome our guest speaker today, Ma'am Avanu Tase, Principal College of Nursing, and all the participants here. And today's topic, according to the session program given, is on KMC. But before we go through the KMC, we will go a little bit on essential newborn care. I am essential newborn care. I'm very fast in speaking, so I hope we will finish within the given time. Yeah, seriously. So essential newborn care comprises care of all the newborns during birth and during postnatal life. So before we go through that, we have sorted 3 learning objectives so that by the end of the session, we will be able to describe the importance of newborn care and the steps of essential newborn care and their benefits, and describe the importance of giving injection vitamin K. So these are the 3 points that we sorted out. So when we see the statistic, out of 5.5 million neonatal mortality and stillbirth, so out of 5.5 million neonatal mortality and stillbirths worldwide, antepartum is 27%, intrapartum 21%, birthday 19%, and rest first month after birth is 33%. So most of the neonatal deaths occur during delivery or on the day of birth. Even for the deaths occurring in the rest of neonatal period care given at the time of birth is an important differential. A lot of deaths occur occurs due to hypothermia, asphyxia, and infection, and it can be prevented by providing essential newborn care to all newborns immediately after birth. So next, before, stop moving. Okay. Before we proceed to the steps of essential newborn care, let us see the sequence of essential newborn care. Here we have sorted 5 sequence. That is first preparation for birth, that is before in the delivery room, like preparing of the delivery room, like 26 to 28 degrees centigrade temperature has to be maintained, and say like warm towel or sterile towel has to be prepared, and delivery kit, ambu bag, and ready for the resuscitation. All those things preparation has to be done before the birth. And then the second one is first 60 minutes, that is immediate newborn care. That is about first 60 golden minutes also we call it. Yesterday during essential newborn care, our guest speaker has explained about the golden minutes, so we won't go that. And then 60 minutes to 6 hours of birth. Essential newborn care is there, 6 hours to 48 hours of birth, care prior to discharge, and care at discharge. So these are the sequence of essential newborn care. We will go to the basic general steps of essential newborn care. The steps here are like call out the time of birth in the delivery room or in the OT. It has to be loud and audible to everyone, those who are present, even to the mother if conscious. And then 2 is deliver the baby onto a warm, clean, and dry towel or cloths, and keep on mother's chest and abdomen between the breasts, so that it can warm can be maintained. At the same time, in breast feeding initiative can be done. And then assess the baby's breathing while drying. At the same time, we have to assess for any abnormality like spina bifida, and any abnormality in the baby's head to toe have to be assessed while assessing the breast breathing pattern. And immediately dry the baby with a warm, clean towel or piece of cloth to prevent hypothermia. And then claim and cut the umbilical cord when cord pulsation stops for 1 to 3 minutes. That is delayed cord clamping. Delayed cord clamping is done to prevent hypothermia. We allow the physiological transfer of placental blood to the babies. And the 6th point, leave the baby between the mother's breast to start skin to skin contact. And then 7, place an identity label on the baby, say like name of the mother, sex of the baby, and date and time of the birth of the baby. Cover the baby's head with a cape, cover the mother and baby with a warm cloth to prevent hypothermia, and encourage the initiation of breastfeeding, and administer injection vitamin K. If the baby is not crying or breathing, if not breathing well, resuscitation has to be carried out, as we have done yesterday in the neonatal resuscitation sessions. And the benefits of essential newborn care. On the screen to the left side, these are the steps that we have mentioned earlier. And then by doing all the steps of essential newborn care, warmth is provided to the baby, and infection is prevented, and mother's milk can be initiated at the earliest, and then colostrum can be given at the time of birth, and then breathing pattern and any abnormality can be detected at the earliest, and then step can be taken, and by delayed cord clamping, neonatal anemia can be prevented. So these are the steps and benefits of essential newborn care. Next is the importance of giving injection vitamin K. The benefits of vitamin K is to prevent hemorrhagic disease of newborn. And here, if you can see, who would receive? All newborns delivered in the facility at all levels, both public and private. And preparation to be used are injection vitamin K1. It comes in 2 forms. One is 1 mg per ml, another one 1 mg per 0.5 ml. Those to be given are like birth weight more than 1 kg can be given 1 mg, and then birth weight below 1 kg can be given 0.5 mg. And then site and route of injection is anterolateral aspect of the thigh intramuscularly. And then who will give? Any healthcare professionals can give. And then where it will be given, it can be given in a labor room, it can be given in postnatal ward if missed in the labor room. In case of referral, the injections should be given at the SNCU, that is newborn care unit, or NBSU, that is newborn unit. When it will be given? Soon after delivery, ensuring after skin to skin contact with the mother, and then after breastfeeding is initiated, then vitamin K can be given. It can be given within 24 hours, but not beyond 24 hours. And then this one logistic requirement is 26 gauze needle and 1 ml syringe and storage room temperature in a dry place. Recording labor room registered, care sheet, referral slips, and discharge ticket of the newborn. And when patient is shifted from the labor room to postnatal or from labor room to neonatal ICU, it has to be recorded and it has to be passed on so that it will not be missed out. And then 80% of newborn deaths in South Asia occur in newborn with small size at birth, out of which 65% deaths are because of preterm and 19% deaths are because of small or gestation age. More than 75% of deaths of preterm births can be prevented without intensive care, and mortality among the small babies can be prevented by special care of these babies over and above routine care. This includes extra thermal care, including KMC, which we will be discussing later, prevention and management of infections, assisted feeding, prevention and management of complications such as asphyxia, hyperbilirubinemia, neonatal encephalopathy. And then follow all tips of prevention of hypothermia in newborn, as we have talked earlier, to cover the baby, to dry the baby, and you can use a radiant warmer if indicated. And postpone the bathing at least for 7 days and practice kangaroo mother care. And in case there is need for transportation, maintain warmth of the baby. So this much for this one essential newborn care. I hope you got it. I hope it's too fast. It's okay. It's okay, no? Fine. Now let's come to kangaroo KMC, that is kangaroo mother care. Kangaroo mother care is a special method of care for low birth weight and preterm infant babies. It was first presented by Dr. Ray and Martinez in the year 1978 in Bogota, Colombia, South America, as an alternative to conventional incubator treatment in low birth weight infants who had overcome initial problems. In a country, nearly 30 to 40 of newborn babies are low birth weight. Conventional care of low birth weight babies is expensive and not widely available. In resource-limited setting, KMC can provide the benefits of high-end incubators. Even in incomplete resource setting, KMC still adds to the benefits to the care. So we need to practice KMC even if in the resource available setting. What does KMC mean? As we have talked, KMC is a special method of care of low birth weight or preterm infant in skin-to-skin contact with a mother or any family members. KMC is, we have added any family members here. Now any family members can give, it is not only the mother alone. KMC is mostly meant for stable low birth weight infant, but just skin-to-skin contact alone is not a KMC. It has 3 major components, that is kangaroo position, that is skin-to-skin contact, kangaroo nutrition, exclusive breastfeeding, kangaroo discharge and follow-up, early discharge from hospital. And before we discuss all these components of KMC, we will be discussing later slides. We will just see the benefits of KMC. If we talk about benefits of KMC, there are multiples of benefits of KMC. We will be discussing one by one. Number 1 to the baby, number 2 to the mother, 3 to the family, hospital, to the community, and as a nation, to the nation. So we'll be discussing one by one here. And to the baby, it prevents hypothermia, improves the rate of breastfeeding, facilitates physiological stabilities in babies, decrease apnea, oxygen requirement, and risks of infection, increase the brain growth and neurodevelopment, and then improves bonding and reduce stress and improves the feeling of security, less cries in neonates. It also reduces pain following simple routine procedure. Better weight gain leads to early discharge from neonatal ICU or hospital. In short, all the 5 senses of the baby, touch, smell, hearing, vision, and taste are satisfied. Now, benefits to the mother. Here also improves bonding from mother to baby, and then feels empowered and relaxed and confident to take care of the baby in hospital as well as at home setting. And it decreases stress in the mother, better supply of breast milk, earlier involution of uterus, and early return to home setting, better follow-up, and even postnatal care of the baby can be done by mother. They'll be more confident on the mother. And then to the family, as we all know that KMC has no cost, so it's economical, and then and bonding not only to the mother and the baby, but it has increased bonding among the family members who are involved in the care of the baby, and better family support involvement in the care of the baby by family members, and early return to work and routine family life, and reduce incidence of child abandonment and abuse. And benefits to the hospital, better use of manpower and infrastructure, and less chances of hospital-acquired infection. Here we have to teach the mother how to maintain the hygiene, and then that we will discuss later, and less burden on nursing staff due to more involvement of mother in her baby care. But we have to train the mother. Benefits to the community and nations, and here decrease neonatal and infant mortality and morbidity, and it is simple, easily applicable, and cost effective, and it results in healthier and more intelligent babies, therefore better quality of future citizens. So these are the benefits, and now let's come to the requirements of KMC. And requirements of KMC, we have protocols, guidelines, and written policies help staff to determine which baby can be initiated and sustained on KMC. Orientation, training, and retraining of staff members are needed, and education material like posters, video, and films on KMC, etc. And then infrastructure conducive for proper and prolonged KMC by mother and other helpers, and preparation for KMC, including counseling of the mother and the family members to ensure prolonged and proper KMC. Breast milk feeding during KMC has to be ensured, and then monitoring during KMC or supervision, and privacy for the mother where possible. Example, provision of curtains between beds, and bathing and toilet facility has to be there, and diaper, a cape, and socks for the baby to maintain warmth. Has to be there. And then next, let's come to eligibility or criteria. For babies, we have birth weight has to be less than 2,500 grams or 2.5 kg, and vitals, heart rate, respiration rate, BP, SpO2 temperature are stable without inotropic support for at least 12 hours, should not be on mechanical ventilator, can be on continuous positive airway pressure, that's CPAP, high flow nasal cannula, with FiO2 requirement not more than 30%, and amnia intermittent hypoxic episode free for at least 24 hours. No umbilical or arterial lines should be there, but arterial line we don't practice here, but umbilical we have done with supervision, and peripherally inserted central catheters, PICC, are okay, but special attention is required here, and stable babies with IV fluids, RT feeding, or oxygen therapy. These are the eligibility criteria for babies, and eligibility criteria for mother or any family members. After counseling the mothers of the family members, there should be willingness from their side, and they should be free from infections, then diseases on chairs like chickenpox, etc., or any serious illness. Hygiene and health status, including mental and physical fitness, has to be there, and support from family members. So excluding criteria are like sick and hemodynamically unstable neonates, babies on CPAP who are not stable and on ventilator, and babies on phototherapy, and sick mother and not availability of relatives. Preparation for KMC. First, that counseling has to be done on the benefits and importance of KMC, and demonstration of procedure has to be done, and we have to ensure that family support will be there, because mother alone, sometimes it's very difficult to prolong the KMC. So when mother needs any other family member to replace, we have to ensure the family support, and there should be recumbent or semi-recumbent position, adjustable bed, several pillows, easy reclining chair. Here we practice with the chair. We have got KMC chair. And then mother's clothing, front open light trace as per local culture, and binder, baby's clothing, cape, socks, nappy, and front open sleeveless. And then let's come to the components of KMC. The first component was kangaroo positioning, that is procedure. The baby is placed upright between the mother's breast, and the head turned to one side and slightly extended, and the hands flexed, hips flexed, and abducted in a frog position. Baby abdomen at mother's epigastrium. Support baby's bottom using binder to prevent slip out and fold when the mother stands up, or if she falls asleep during KMC. The baby's breathing should not be impeded by the binder or the positioning. Maintain privacy for the mother. You can see in this picture. after the procedure, we have to make sure to do this checklist or monitor this. That here, if we see in the picture, face can be seen. Okay, head is in a sniffing position, and nose and mouth are not covered, and head is turned to one side, and neck is straight and not bent and well supported from behind, and then chest to chest with mom, preferably between her breasts. Legs are flexed. Yeah, you can see here also. Legs are flexed below the breast in frog position. Bottom is supported from below. Mother is little upright, not flat on bed or chair. Cover the bed with blankets. Both are watched when sleeping. Baby is being monitored for breathing, color, temperature, etc. So this is the picture you can see. And then going back, this is the picture we practice in our people. These are the from our side. Next is KMC feeding. KMC feeding, the second component. Exclusive breastfeeding should be encouraged. Direct breastfeeding or express breast milk by spoon or tube along with KMC. Optimum feeding and growth must be ensured, and mothers should be trained on how to feed the baby, and storage of EBM extra. Storage of EBM we will see in the next slide. And she may express milk while the infant is still in KMC position as holding. As you can see in the picture, the infant near the breast stimulates milk production. Extremely low birth weight infants will require IV fluids to begin with. So human milk storage guidelines, according to the CDC here, freshly expressed or pump milk can be stored in the room temperature for up to 4 hours, in the fridge for up to 4 days, and in deep freezer for 6 months is the best, up to 12 months is acceptable. If from the fridge, if it thawed or previously frozen, we can keep in the room temperature for 1 to 2 hours and up to 1 day in the in the refrigerator, and not to put back into the freezer. So and then we have to teach them how to bring back to the normal temperature. We should tell them not to boil it or not to heat the milk, because it will spoil. You have to keep in the room temperature, or else if you have to 1 hour, at least 1 hour before feeding, we have to remove from the fridge and keep in the room temperature. Then it will come back. Say in a cold place like Ceylon, it's difficult. So if you are in a hurry to give, then you can tell them they can use in a you can take warm water in a bowl, and then they can make it sit on the warm water, but not to boil it and not to stir it vigorously. It has to be swirled. So this is the human milk storage guidelines. And then the types of KMC. There are 2 main types of KMC. That is continuous, is more than 12 hours in 24 hours, that's continuous. And intermittent, short, that is up to 4 hours in 24 hours, extended 5 to 8 hours in 24 hours, long 9 to 12 hours in 24 hours. Here in our practice, in initial stage, we were below 4 hours, so we are target, we went to 4 hours in 24 hours, and then we went up. After a few months, we went up to 5 to 8 hours. Now we are at this 5 extended, that is 5 to 8 hours, and our next target is 9 to 12 hours in 24 hours. So the duration now, the minimum duration should not be less than 1 hour to 1.5 hours, so that baby can get a complete good sleep cycle. Why we take 1.5 is 1 hour there should be complete sleep should be 1 hour. So half an hour handling, it takes baby takes time to sleep also. We give 1 complete good sleep cycle, so we take it 1.5. Okay? And frequent handling may be stressful for the baby. The duration can be gradually increased as much as possible until it is almost continuous, usually 10 to 12 hours a day by mother with comfort. And then if possible, other family members like father, grandmother, and others can help by giving congruent care to offer some relief and rest to the mother, or even replace her. The infant needs to be removed only for changing diapers and clinical assessment, or for mother's personal needs. Whenever KMC needs to be interrupted, the baby should be placed or kept in a warm, safe, and supine position. There's discontinuation of KMC or criteria to stop KMC. KMC can be continued after discharge until the following criteria are fulfilled. Infant weighs more than 2.5 kg, that is 2,500 grams. Our infant reaches 40 weeks of gestational age or term gestation, or if baby feels uncomfortable, pulls limbs out, cries, and pews every time when KMC started, KMC can be discontinued. And there's special consideration on who can do KMC are like, if mother is not available, any family members can give. And if no family members, like no parents are there, then with the consent of immediate family members, any volunteer person can do. And twins can be placed on either side of the chest of the mother. And then the mother can sleep during KMC. It is important that baby is always securely positioned. Do not bear the baby till the weight gain is about 2.5 kg or sponging, but sponging can be done. Discharge from hospital and follow-up. The third component of KMC, the infant is stable in terms of respiration, heart rate, and color, not on any parenteral medications, maintaining body temperature on mother's bed for at least 3 consecutive days, and gaining weight of 15 to 20 grams of body weight for at least 3 consecutive days is preferably, and then accepting direct breastfeeding or ABM by spoon, cup, or traditional feeder paradigm, and mother confident to take care of the baby and continue KMC at home, including KMC. And then family support is assured for allowing mother for KMC, and close follow-up is a fundamental requisite for KMC. Regular visits for growth monitoring immunization must be combined with special follow-up for neurodevelopment, follow-up for preterm and low birth weight infant. And first follow-up should be 1 week before, followed by once a week, followed by fortnightly, followed up in the next 2 visits. Additional follow-up visit may be done until 40 weeks of post-conceptual age or the infant achieves about 2,500 grams of weight. Subsequent regular follow-up for the screening of neurodevelopmental morbidities should be established with suitable protocols. I think I'm going too fast. And then during discharge, we have to know the danger signs, and we have to explain to the family, mother and family members about the danger sign during KMC. Here we see dangers. If apnea, slow breathing, or sinuses is there, we have to tell the mother to stop KMC immediately and stimulate the baby and seek help from nearby healthcare professionals. And if the baby develop hypothermia, but otherwise where the baby's feet and other extremities are cold but otherwise active, we have to ensure that the baby is covered well, including head, palms, and soles, and remove the wet diaper, and ensure that the room temperature is maintained not less than 26 degrees Celsius. And if it is less, switch off the AC or fan or close the nearby window. Continue KMC. If baby does not become warm in 30 minutes duration, seek help from nearby healthcare personnel. And if hypothermia, the whole body is cold to touch, then we have to tell them to seek help from the nearby healthcare personnel without delay with KMC in practice. And if the baby has hyperthermia, and if the baby's body is warmer than usual and otherwise baby is active, we have to ask them to stop KMC, remove the tight clothes, keep the baby in a good ventilated place. If temperature has not come down in an hour or baby is not active, seek help from the nearby healthcare personnel. And if there is fast breathing, more than 60 per minute in less than 2 months, or more than 50 per minute in 2 to 12 months old baby, and chest indrawing and grunting is present, we have to seek help from nearby healthcare personnel without any delay. Because these danger signs and then actions to be done has to be told to the patient mother and baby's mother and the family members before the discharge. And then the challenges that we face in outdoor neonatal ICU, which is in pediatric ICU here in Negrims, are like the challenges we face where mothers are supposed to do KMC. We did not we didn't know that other family members can do in place of mother, and no proper counseling for the mother and family members was there, and privacy issue was there, and timing was not recorded when we start initially, and KMC chairs or bed were not available, and proper training for the staff was not there. Staff were not sensitized on needs of KMC, and we were depending too much on doctors for written orders, which leads to delay in initiation, and there was less manpower issue. So these were the challenges that we faced. And then the steps that we have taken, the background is of our Argo neonatal ICU, which is in pediatric ICU. The steps taken were, if you see the picture of the mother was sleeping, we have to observe during this time. And then we encourage or involve the other family members to participate, apart from the mother, in giving KMC. And the counseling to the mother as well as the family member was done on the benefits and importance of KMC. And curtains were provided. Here in the picture, we removed the curtain. There's a curtain, but we pushed to the back because all the mothers were there. And if in case father is there or any like father or uncle are there, we provide the curtain to provide privacy. And KMC hours were recorded in patient's file, and KMC chairs are provided. If you can see the chair here, and then training for knowledge update for the staff were done, and then KMC initiated on babies who fulfills the criteria. That means we don't wait for the doctor's written order to start on KMC. Any baby who fulfills the KMC criteria, we start in KMC. But here we have added another footstool to raise the foot. We have added that too. Okay, these are the steps that we have taken. And then if you see, these are the pictures the recent pictures that we have taken from PICU. It's a father giving KMC, and you can see here our mother giving KMC to a twin baby, and you can see a baby on CPAP on KMC, and this baby also on CPAP with all the lines here. You can see with the IV lines and feeding tubes on KMC, and this is the mother during giving KMC during COVID with mask. So KMC is a low-cost, simple, and evidence-based method of newborn care, especially for term and IUGR and low birth weight and preterm. It must be included in regular program of newborn care in our country. I think with this, thank you.
Thank you, Sister Amina, for the wonderful session. By the time you can, those who are having any queries, please write down in the chat box. Okay. And regarding that previous class pre-test, post-test, don't do a normal message or message me to WhatsApp. Okay. So now I request Madam Tasa for her input in this topic. Now I request you to say something about the KMC.
Actually, I want to congratulate Amina. She has done a good job bringing about, talking not only about the essential newborn care, which we know saves a lot of our baby's life. And not only that, she has also extensively covered regarding why vitamin K injection is very, very important in giving to the neonates. And then she also covered about the KMC. And I'm very happy to know that the nurses of our neighborhoods, they are doing very well. They could not only do things, but they are able to identify the challenges. And not only the challenges, they have also solved the problem. They have also made some decisions. And that is what nursing is about. These neonates, they are depending on us. And one thing I really liked was that they had not only ensured that KMC chairs were available for the mothers or for the attendants or for the relatives who were giving KMC. But one thing I was also thinking at that point of time when I was looking at the pictures was whether the mothers are comfortable to sit for, more than 1 hour, because we know that the minimum time which the KMC should be given for is 1 hour. So whether the mothers are comfortable in that chair. And then I was so happy because she told that they have started providing the stools so that they can put rest, so that the mothers or the person who is giving the KMC can comfortably sit and place their foot on that. And the safety issue also, they have taken care for that. I think that is very commendable. Congratulations to all the nurses of PICU. I just want to say that, like I'm almost repeating what she has said, but I would like to add that yes, kangaroo mother care, it is a very effective alternative to the incubator for the preterm newborns. And even the WHO have recommended that it should be done not only in the developing countries, but it should also be done in the developed countries. It is very, very cost effective because we know that we don't need anything extra to buy to give kangaroo mother care. It can be given by a person who is willing. Yes, counseling is one very important issue which has to be taken into consideration, because normally when we look at preterm babies, they are very tiny and they have complications, you know, and if you look at them, they don't have many fat adipose tissue developed. So even their look, they look very skinny and very thin and very tiny. So counseling is very important regarding the positioning, regarding the duration, regarding the safety. And also, not only that, we also talk about breastfeeding. We know that breastfeeding is not only it is provided by the mother, but it's also specific to the species. That means, like, if we give cow milk to the baby, or if we give any other milk to the baby, that is harmful to the baby, because we know that, like, when we give cow milk, when we compare the milk of the cow and the human milk, the protein composition is different. The digestibility of the baby, already they are still very young, they are very new to this world, and they have been introduced to such complex protein, becomes difficult to digest. When you are giving additional milk, or when you are giving additional food to the baby, what happens is that you are giving too much carbohydrates. So what happens? Baby just put on weight, and it is not a healthy weight. We want baby to gain weight, yes, but it is not a healthy weight. So, like, we know that human milk, it is a very unique dynamic nutrition which is meant for the baby, and we also know that we have to give it exclusively for 6 months. That is your exclusive breastfeeding. And human milk also, we know it directly contributes to the immunity of the newborn, because of it shapes the gut microbacteria and it helps in the milk oligosaccharides. So I think, as we know, we have discussed in detail, and I think Amila has done enough, and I think it should be enough. I think we are ready to take questions. Yeah.
Okay, so ma'am, one question is there. Injection vitamin K, if not given at birth, then can we give within a 24 hours, or we can also give even after 24 hours?
Injection vitamin K, we are giving within 24 hours.
So Stamina, you want to answer? These questions. If the injection vitamin K is not given at birth,
we can give in Negrins, we are giving, right?
We are giving within 24 hours and after.
Within 24 hours, but we are giving.
Okay.
After 24 hours also we are giving, but preferably it has to be within 24 hours.
Okay. So I think, hope, Sumi, you got the answers. Usually we are giving within the 24 hours. If you missed out because of any other reasons, then yes, we are giving after 24 hours also.
It is always better to prevent than not to do it.
Any questions? I think Amila sister has done the presentations very nicely. I'm not seeing any. You can ask any queries. If you want to share your experience also, Bhunesh, can you give access to talk them also, so that if anybody, because here 1,000 nurses are there, and then, you know, it's a rare chance that we are coming in one platform. So it will always good to share your experience among each other, because we all are in learning phase. Okay. So I request, if anybody want to share any experience related to anything, we are very much happy to hear your experience. Okay. So another question is, like, what if the baby is 2.4 kg and above 40 kilograms? It is compulsory to do the KMC. Sister Amila, you want to answer this one?
2.4 kg. Yeah, we can do it.
See, all the babies who are below 2.4 kgs we are giving, 2.5 kgs we are giving.
You can
as
do
long
it.
as they're hemodynamically stable.
Unless if the baby doesn't fight, or like whenever we, as I mentioned earlier, also whenever like baby fights, no, or like, you know, we cannot put on, we don't want to force the baby. to KMC, so we can do it. Otherwise, there's no problem.
Okay, I think you got the answers and another question, is there exclusive? Another question is also there, like exclusive feeding for 6 months is the best. But what happens when some moms produce less breast milk and they rely on the baby formula? Actually, in this regard, no, we always say the exclusive breastfeeding. I think everybody knows, because everybody knows that one is our first preference is breast milk. Okay, but if somehow if the usually when we are doing ANC counseling also, because if the primary mother is there, then initial breast secretion is very less. I think everybody, those who are mothers and all, you have your own experience, right? But even though we will encourage them to feed, because even the baby mouth when keep on sucking, that will help in stimulating. So it will help in breast milk secretion. So that's why our first preference is breast milk. Okay, so we don't suggest for baby formula.
Yeah, I just want to say something in that. I just want to add to what she has said. I agree with her completely that we only advise them to go for exclusive breastfeeding. Now, in the initial period, breast milk secretion will be less. And that is exactly what the baby needs. You don't have to give in addition to that. And as long as the baby is, you are putting the baby to the mother's breast for suckling, okay, we call it non-nutritive sucking. Even we can do that. And as long as the mother is not having problems like your inverted nipples or those cracked nipples, as we call it. So as long as mother is not having those issues, then whatever the mother is producing is enough. And if you feel that mother is not able to produce more milk, then you can always take the dietary consideration of the mother, because there are certain diets which really help to increase the breast milk in the mother. And I'm telling you this from experience. I'm a mother of 2 kids. So there are certain diets which really help in the increasing the breast milk. So you can go for that also.
Thank you. Yeah. Another have given asked for what are the advantage of cord clamping.
I think
actually nowadays, nowadays we do a delayed cord clamping. I think we have asked in a pre-test also. So usually we will wait for 1 to 3 minutes, and especially if you are working in a labor room, that we will check the pulsations. If when you are checking for the umbilical cord pulsation, if it's stopped, then you can cord. While we are doing is like when you are delaying cord clamping, then what will happen, at least baby will receive 80 ml of blood. Somewhere I have read that, if you are delaying little bit, at least baby will receive 80 ml of the blood, because the blood that is there in the umbilical cord and all. So that amount of blood will receive by the baby. And that's a huge amount, that much amount. So that's why we always suggest to do the delayed cord clamping, unless and until if there is no any contraindications. Okay. That is there. And here I just wanted to add one more experience because during my career time. So when we are teaching about the KMC, when Sister Amila nicely told you about the positioning, right? I think most of you are performing also, but you have to be very careful whenever, they are doing the KMC, because during the entire process, when I was working in Bihar, we are also giving training to the nurses. So during that times, what we have done, we have taught about the KMC. It was in the month of December, and we taught KMC. Then after that, when we next day went, actually the nurses are very excited and they practiced also. What incident had happened is like, when the baby, they are keeping yourselves. Bhunesh, can you remove the access to talk? Okay, thank you. Okay, so what happens when we went next day? Then there was one incident where baby was died when doing the KMC. Actually, what happens? They have taught to the mothers, and the grandmother was keeping the baby in a KMC positions, and she kept, because we are telling minimum 1 to 1.5 hours. Okay, so when she kept the baby for such a long period of time, then she didn't check. I think she didn't check the position. She didn't check the baby in between also, and then I think she kept the positions wrong. So when she wanted to remove the baby from her lap, that time baby was already died. So that was the incident, and that was also male baby. Okay, in Bihar, and male baby is like huge thing, and even for everyone, baby is like very much precious. So that kind of incident will happen, and this incident we have witnessed by myself. So that's why whenever you are telling the positioning and everything, please ensure. Even if the positions of the baby, especially the baby mouth and then eye contact need to be there. Okay, so please ensure that one. I think other questions. Anyone wants to share any experience like that, so that at least other will take care of those things when they are teaching the KMC or anything. Any questions you want to ask? Does every normal delivery baby needs a KMC? No. I think Sister Emila has nicely told the criteria for KMC.
Normal delivery baby needs KMC. Yeah, if baby fulfills the given criteria, then can carry on KMC. No, be it normal or like normal delivery or cesarean. I think that is the one, normal delivery.
Yes. If the
criteria
is a normal
like,
delivery, but
below 2.5 kg.
I think you got the answer. If the baby is below 2.5 kilo, then
Born before 37 months.
Okay, so
because the benefits that we have discussed earlier was in like weight gain, and then in precisely this one weight gain, and then increase the breastfeeding and bonding, and there's so many other benefits that we have talked about it. So like if baby is below 2.5 kg, then and if the baby is stable enough at home, then it can initiate the KMC. There's no complication on KMC unless you have to take it, as Nanuka has explained earlier, that it should not be covered too tight like that. So otherwise, there's no complication in doing KMC. Rather, it has more benefits.
I am not seeing any questions. If anybody wants to speak, you can raise your hand. We will give you access to talk. Because if you are giving access, then you will see, hear lots of background noise. If anyone wants to share regarding KMC or essential newborn care, please raise your hand. No more queries.
Yeah, one is here. LBW baby with fever. Can we do KMC with fever? LBW.
Low birth weight baby with fever, can we do KMC? That's a fever, like we have to monitor, like you have to take control of the fever, then continue KMC.
Yes, because in KMC there is no any adverse side effect.
No side effect. There's no problem. The thing is, when the baby is very on hyperthermia, and if you cover up, then fever might increase. So you take care of the fever, and then you can always continue KMC. There's no complication.
When can post-LSCS mother attend a KMC?
Post-LSCS. It depends on the mother, these two, like post-LSCS mother, right? So like on the next day also, if you can sit up, you can start, no problem. And in my case, in my experience, on the night itself, I think I gave my baby on my chest. Even though it was my first baby, maybe I was too excited. So like if you can carry it, then no problem. On the first day itself, not even
it doesn't have to be the mother, it can be the father, it can be a relative also, we can do that.
If the mother is very sick and admitted in ICU, then father can do, grandparents can do, auntie, uncles can do, any volunteer with the consent of the parents can do.
Yes, in the KMC, so that's why anybody, we just need a skin-to-skin contact. Okay.
Sometimes in cold places, like they said, like I do not take bath, and they don't want to take bath, they refuse also. Like if hygiene is maintained, even if you don't take bath, if sponging is done, then they can do. Some like we have response from the patient party that I didn't take bath, I have to go home and take bath. No, like that thing they come from far, but they refuse sometimes. But we have a bathroom, they can take bath if they want to. Otherwise, they can do sponge bath. No, like they can do like hygiene. If hygiene is maintained, then.
Any questions?
As well, no matter if the child is having fever, whether we can give vitamin K. But vitamin K is we are going to give within 24 hours. And fever as
Fever when
such,
you 24 hours, no,
I don't think fever will be there within 24 hours.
I think you got, here's something else.
Yeah.
Okay.
Can you give vitamin K?
I think Lucy, you got the answers because usually the vitamin K we are giving as soon as baby is getting delivered, we are giving a vitamin K. Usually I've seen during my practices, like within in a liver room only, they used to give the vitamin K. I think
Yes.
during the time there might
Fever
not be
also.
fever, but yes.
But it is not a contraindication to vitamin K.
You saw? And because of this postage and
Okay, after normal baby, till what time can we give one? But no, like 7 days.
Yes.
For 7 days we don't give full baby bath. We can give sponging.
Anyone wants to share your experience, because only from our side we are talking. Anybody wants to share any experience, you can raise your hand. Okay, we have 2 more minutes left. If anybody wants to share your experience and all, I have not seen any more questions in the chat box. Anyone, if you want to share your experience with the teams, you can raise your hand. I have not seen any more queries in the chat box. Please post test of that previous one date. I'll share in the chat box. In WhatsApp group, I'll share you. I will mention the date and pre-test, post-test. Please check the date carefully and then fill. Okay. And also during doing the pre-test, post-test, please read the topic heading. What is the dose, ma'am, that we can give for vitamin K?
Below 1 kg, 0.5 mg, and above 1 kg, it's 1 mg.
I think you got the answers. So we have shown the chart also for that.
It was there in the chat.
Yeah. So if it's below 1 kilo, then we're giving a 0.5. And if it's more than that, we are giving a 1 milligram. Sorry, I forgot. Ma'am, it is necessary to mix the vitamin K with distilled water?
Vitamin K distilled water, no.
No, it comes, it's a prepared solution.
one, yeah,
It's a prepared one. No need to
Yes.
do anything.
Yeah. Because
It
I've
comes
never
prepared.
See,
seen.
we have to give, I think they mean to say in pediatric, most of the drugs we dilute it.
Okay.
They mean to say that, but like here, we are giving IM. And if you see the muscle, it's very small in a newborn baby, you know, so like that small amount. And then vitamin K is, we have mentioned that it comes in 1 ml and 0.5. 1 ml only, 1 ml, 1 mg, and 1 ml, 0.5 mg. I mean, like if you want to give 0.5, then we can take the 1 ml, 1 mg, 1.5 ml, that 0.5 mg only. The 0.5 is okay.
Yeah. So I think main conclusion is we will not dilute vitamin K with any distilled water. Okay. PPT and all I'll give you in the WhatsApp group. Okay. Yesterday one also I'll give you. Yesterday one and today one I'll give you. Previous presentation I have already given to you, but those who have joined lately, once again I'll give you. Okay, I have given the WhatsApp link here. You can directly click the link and join the group. Okay, once again I'll share